Okay, well, so welcome everyone to this latest talk in our TAPAS International series. As you know, TAPAS network is associated with air pollution in schools, and we've run a series of seminars over the last 3 years. And in this particular sequence, we've been focusing on international speakers, but we're going to consider leads to be out of the country for the purposes of today. Few housekeeping remarks to say that this is recorded, and please put your questions in the chat for our speaker. And I'm very pleased to say that today we have Professor Steve Griffin. He's the Professor of Cancer Virology at the Leeds Institute of Medical Research. Steve has graduated from Cambridge, you may have heard of that, and moved to Leeds in 2001 and has been there ever since, starting off as a postdoc and ending up in his current role as professor. He's focused on antiviral therapeutics, as well as causative and also potentially curative viruses in human cancer. And since the advent of COVID, he's been actively involved with scientific communication and policy to improve public awareness and to counter disinformation across the social and mainstream media. So he also supports charities focused on vulnerable populations and children, including during the COVID inquiry. And we're very pleased because we felt that although TAPAS is associated with air pollution, clearly airborne disease has many things in common with airborne pollution. And we, through other projects, many of the people on TAPAS are also involved in COVID work. Steve was the co-chair of Independent SAGE and looking to promote forward-looking vaccine plus approaches to dealing with both the ongoing pandemic and the next one. So it's a great pleasure to have you, Steve. His title of his talk is, I can't find the title of your talk, but he will give the title of his talk. And I'm going to hand over to him now to give his presentation. So thank you.
Thank you, Paul. Thank you for a very kind introduction. I will just share the screen. Hopefully that's showing up.
Yeah, that's great.
Okay. Pointer, where's it going? Okay, so thank you. And as Paul alluded to, what I'll be talking about today is more to do with my role in Independent SAGE and things that we've done during the pandemic to try and help support people of various ilks. And what I'll be talking about today is my own views around why we think a fresher perspective is needed on childhood COVID-19, because I think it's something that people kind of just assume isn't really an issue in many cases. And I think it all ties in very much to the idea of controlling air pollution, air quality, and cleaner indoor air for, in particular, schools, but I'll mention other circumstances at the end. But I'll only touch on that at the end because I don't really need to teach this audience anything about air quality. What I am going to talk about, though, is the need, really, for, oh goodness, why is it doing that? There we go. The need, really, to recognize the importance and the troubles that can be caused by the SARS coronavirus 2 infection in children, okay? What I'll very quickly tell you is that we do, in fact, still remain, virologically speaking and disease speaking, in the midst of an ongoing pandemic. No matter what people may tell you on the news, we are certainly in a situation where this virus is still behaving as a pandemic virus. And whilst the risks are far less than older people, children are at risk from acute and indeed longer term problems associated with infection with this virus. And I'll talk a little bit about the numbers behind that and the reasons why it's perhaps a little bit different to the disease in adults. We also know that the vaccines, which are an incredible achievement, they were generated within a year of the pandemic breaking. We know that they're extremely safe and effective on a population scale. Of course, there are issues sometimes at an individual level in children. The lower dose in children makes them very, very safe in under 12s. Of course, they're not perfect, and especially in the Omicron era, they're not as good as protecting against infection. But what they do is give good protection against severe disease. And this is particularly important for under fives, as I'll talk about shortly. And it's a sad fact, really, that the UK really is a bit of an outlier in terms of children's vaccinations compared with other countries such as the US and so on. But vaccines, as brilliant as they are, in my view and in the view of many other people, and I think as we're actually hearing quite a bit in the inquiry at the moment, we can't just rely on those vaccines on their own because they're not sterilizing vaccines, they don't prevent transmission. So if you're ever going to get a handle on this virus and stop it mutating like crazy, then we really do need to help the viruses, sorry, not help the viruses, that would be a bad idea, help the vaccines by applying mitigations as well as vaccinating people. So very quickly, just to discuss COVID itself, so coronavirus disease caused by SARS coronavirus 2, it really is not your average typical infection. Now, many viruses will cause very complex pathologies, and I know this isn't a virology audience, but I just really wanted to make the point that whilst this virus is an airborne respiratory infection in the sense that it tends to pass between people's upper airways and lower airways, it doesn't necessarily mean that the disease it causes is entirely centered around the respiratory tract. Now, in the first stages of the epidemic, back in 2019 and 2020, the most severe pathology was indeed associated with the lungs because we had a lack of population scale immunity. This was a novel virus, and it was causing this hyperinflammatory reaction known as acute respiratory distress. This, severe acute respiratory syndrome is why the virus is named that way. And this was really the major problem prior to us developing vaccines, et cetera, et cetera. Now we understand that partly because this virus is getting into cells through this angiotensin converting enzyme 2, which is prevalent on multiple different tissues in the body. We know that this disease is affecting multiple tissues. We also see persistent infection in multiple tissues. And so the pathology of SARS-CoV-2 has changed slightly, actually, over the pandemic, from being one that's majorly a respiratory disease to these other manifestations. And indeed, if you talk about these different manifestations, you see different symptomologies between different viral variants, some of which cause perhaps more gastrointestinal features. So the Delta variant was very notorious for causing gastrointestinal problems. But we also know that from losing senses of smell and taste, etc., this thing is affecting neurological pathways. We see disturbances in metabolic pathways and whatnot. And indeed, you can see all sorts of different inflammation in different organs, including the genitals, indeed. And subsequent to this, either as a continuation of the acute disease, as a longer-lasting disease profile, or indeed as a relapsing, intermittent, long-term problem, we know that there's been a dramatic increase in what we would call a post-virus syndrome. So this is loosely termed long COVID. And this, again, has an incredibly complicated etiology. And it's different sometimes in adults than it is in children. It's more common in adults than it is in children. But again, this is a multi-tissue, multi-organ, multi-etiology condition, which can have huge different numbers of manifestations, and indeed can again have a kind of latent course where you don't necessarily have a continuation of symptoms from the initial infection. You can see things happening over a much more sort of slow burner course, which then will come back and relapse, things like cardiovascular problems and clotting, for example, the incidence of diabetes, which I'll touch on later on in the talk. And again, this pathology is incredibly complicated. And we really, I think, would be quite naive to say that we understand everything about the pathology caused by this virus, despite the tremendous research efforts that we've made to try and understand it. And so I think a general message of the talk I'm going to give today is that we really don't understand enough about this virus to try and sort of just close it away in a closet somewhere and move on. And we need to think and safeguard for the future. And the other theme, I think, which maybe I could have changed my title to, is that a small percentage of a very, very large number is still a pretty large number. So just bear that in mind as I go on. Because things have changed. The way we're dealing with this pandemic has changed quite considerably. And throughout the early stages of the pandemic, many of us embraced this idea, which was first put forward by Ian McKay in Australia, about the idea of a multi-layered pandemic mitigation approach. And this involved vaccines, of course, when they first turned up. And of course, something that we're all very concerned with here today is about the sorts of population scale mitigations that we can use to try and attenuate this transmission of these viruses. But you can, of course, add all these other layers of protection, which none of which are perfect, but between them, the idea of the Swiss cheese model is that between them, the chance then, if you apply enough layers of protection here, is that you protect yourself eventually from the virus infection getting through to you. Now, the problem is that we are, as I've sort of stupidly said at the top of this slide, we are running out of cheese. You know, we're scaling down vaccines, particularly at the moment in the UK. We're not testing anymore, really, in any sort of meaningful way. The idea of wearing a mask has become some kind of strangely politicized football statement of freedom, whichever newspaper you choose to read. But really, one of the things that we can do, and really that we should be doing more of, and I think that we should be seeing more of in schools, in hospitals, and everywhere else, is this idea that we can improve the indoor air quality. And that's one reason why TAPAS is such an amazing set of people working together to improve that. And of course, the benefits that we would implement there don't just have implications for COVID, but other infections as well, and of course, pollution, which I obviously don't need to tell this audience about. So we really are in a spot of bother here because we are losing all of these slices of cheese. And the problem with this is that, as I mentioned at the start of the talk, is that this pandemic really isn't over. This virus is not behaving with any kind of seasonality. It's not settling down to a low level of prevalence in the population. We're not seeing single waves. We're seeing impactful waves of viral disease, which are dictated almost entirely by variation in that virus itself. So, and that's not in balance with our immunity. So whereas in a seasonal endemic virus, you would see a gradual change in influenza, for example, and SARS-CoV-2 is changing about 3 or 4 times quicker than the fastest flu that we know of, the H3N2s. And our population immunity is very high against influenza. In SARS, we see waning immunity, which is waning very quickly. We're seeing younger people, in particular in the UK, not being vaccinated, which I'll come on to. And this virus is incredibly variable. And so we are still seeing a huge number. This is from 2022. The data from 2023 is a little bit piecemeal now because everything stopped in spring. But we're still seeing this huge number of people put into hospital, which of course translates to huge NHS pressure. And of course, it's consistently happening throughout the year. So for example, the NHS is not getting its summer, not break, but its summer chance to sort of catch up on the backlog that it otherwise may have done from winters past. So this virus really is causing tremendous NHS pressure. You won't see it in the news anymore, but we are still seeing thousands of people admitted at the peaks of these waves that we're seeing. We saw 5 waves during 2022. I think we have 4 so far this year. So this is in no way a seasonal cold, something that we can just deal with as a normal, as we might want to call it, endemic virus. And just to put that in sharp contrast, I'm showing this for not reasons that would seem obvious. I'm not trying to minimize influenza in any way, shape, or form. Seasonal influenza, even not pandemic influenza, seasonal influenza is still a very impactful, damaging illness. We don't do very well at controlling it. But this is just to show the scale of infection that we're seeing with SARS-CoV-2, but also the fact that when we put in pandemic mitigations in 2021 and through into 2022, these mitigations not only combated COVID, they combated influenza as well. And you can say the same thing about RSV. We basically had no flu in 2021. But of course, when the flu came back in 2022, there was unfortunately no extra vaccination drive to try and prevent that increased susceptible pool being more adversely affected. So we had a big wave of flu in 2022. But again, this is just to show that this virus, this SARS-CoV-2, is incredibly variable. It's still behaving like a pandemic virus, and it's going to continue to cause us problems unless we do something about it. Unfortunately, despite the fact that we're thankfully no longer having these enormous peaks of damaging disease and death that we saw in 2020 and 21 prior to the advent of vaccines, unfortunately, the area under the curve that we have here, because we're not controlling viral prevalence in any meaningful way, is still considerable. So we've moved from something like 90,000 deaths down to 70 odd and down to 33,000-ish last year, caused either directly or at least attributable to COVID. So these are certificated deaths that the ONS have guaranteed that we know of. And so far in 2023, in November it was 16, we're probably looking at something over 20K by the end of this winter, unfortunately. So I think the argument that we are indeed living with this virus isn't working terribly well at the moment. And I think there are various reasons for that, but I'm just going to focus on children and their vaccination status and mitigations on this talk. But what's important to remember as well is that this virus is causing predominantly the underlying causation of death, as opposed to influenza, where influenza generally tends to lead to a secondary complication such as bacterial pneumonia. That again is not to sort of try and play viral top trumps. It's just to illustrate that this virus is different, and so we should be trying to deal with it differently, in my view at least. And this is just data from 2023 to show you again that even though we have such high vaccination coverage, even though we've had such high number of infections and theoretically should have very high population immunity, we are still seeing peaks where hundreds of people are dying every week. And this data goes right up to October. This is going to continue to climb, unfortunately, because it lags behind the wave that we've just come through. As I mentioned at the start as well, this disease is not just confined to an acute respiratory problem. And unfortunately, a lot of the metrics and strategies that we come up with, including vaccines, are based on that sort of assessment in terms of the vaccine cost effectiveness, antivirals cost effectiveness, et cetera, et cetera. This disease is causing a profound amount of long-term morbidity and chronic illness. And unfortunately, it can happen regardless of whether you had severe symptomology or even quite mild or even asymptomatic symptomology in the months and weeks following this. And this is just a graph showing in the UK how many people have thought, at least the last sets of estimates, to be suffering from long COVID or PASC, whatever you'd like to call it. And I'd just like to draw your attention to the fact that whilst it is still lower, the number of children and young people affected by this very devastating problem, which can last more than a year, more than 2 years. Indeed, we have many people in the charities I work with who have been ill with long COVID since 2020. This can continue to affect people at all ages, regardless of your initial disease outcome. And it's a major problem recognized by the WHO and ECDC, et cetera, et cetera, et cetera. And we're seeing huge impacts on the workforce, and recovering from the pandemic with a workforce that's becoming increasingly chronically disabled isn't, of course, a brilliant idea. And one thing that the Living with COVID strategy really takes no account of is the idea that unlimited transmission, unlimited disease prevalence, allowing this virus to continue to spread as it is, does nothing to reduce the incidence of long COVID. So, of course, decreasing the number of virus particles in the air, mitigating and preventing the number of infections could have a huge impact on this going forward. So I mentioned that this virus isn't behaving like our standard seasonal illnesses, not that our seasonal illnesses should be taken trivially at all. And this is the reason why. So you may remember towards the end of 2021, this incredibly adaptable and prevalent strain of the virus, Omicron, emerged from the African continent and caused a devastating wave across the planet in most countries, not all. And that has been the case since. This virus, although it is actually more diverse within itself than some of the original variants were between one another, is still classified as the same variant of concern by the WHO. And people have actually taken to start naming different variants of this to try and aid in people's understanding of when there's a new variant on the loose. But we can see that this has evolved at a tremendous rate over time. We may have heard and remember some of these terminologies through the news and scientific papers, of course, over time as you've seen these things evolving. At the moment, so this is moving around in time, the predominant strains are these XBBs, which are actually a recombinant virus between two forms of this Omicron variant. But this virus continues to surprise us. It's not just a standard drift and a gradual change that we've seen in influenza, for example, which is what this linearity kind of reflects. But actually what we find in this virus is that people who have had long-term chronic illnesses harbor these viruses, and in the long term, they develop multi-immune evasive variants of this virus. And just recently, we've seen the emergence of one such virus like this, just as BA1 and BA2, the original Omicrons, did those years ago. It's emerged from somewhere we really don't know where from in the world. And this separate BA2.86, which has been nicknamed Pyrola, hoping that it may be called Pi eventually, certain people are. But this is an incredibly diverse and different form of Omicron compared to what we've been dealing with for the last year or two. And what we end up with these highly changing variable viruses is this, what people term a variant soup, if you like. So these are all the different subvariants over time, color-coded. This is UKHSA data, just exemplifying the fact that we're never really talking about one single virus when we talk about SARS-CoV-2. When seasonal influenza sweeps through every year, we tend to have two main strains, and of course the flu B. They don't tend to be changing that much within a wave as they come through, but it's a very, very different case for SARS-CoV-2. And if we just picture just a year ago, the picture of these viruses back then a year ago was very different to what we're seeing now. And this is that new virus, the BA2.86, that's steadily growing in the UK and is predicted to become dominant before Christmas at some point, we think. So this again is just showing you the huge diversity of these viruses. And this gray line shows you the lack of testing that we're doing at the moment. So this is based on much smaller data sets than we ever started to have prior to April this year. Unfortunately, the amount of genetic surveillance we have, and because of the lack of testing, has plummeted. So we're only really guessing still at the prevalence of this virus, but we also know that it's huge. Still, every wave is infecting millions of people across the country, and it's not just one virus. However, we do tend to see one virus dominate once after a while, but this is unusual at the moment because we are seeing coexistence of multiple strains at the moment. We're not sure why. There are countries such as Sweden and Finland at the moment who are seeing sharp spikes in cases without any sort of changes in the gradient, the variant portfolio that they're experiencing. So it could be that there's an interesting dynamic going on with the fact that people haven't had a vaccine for a very long time, and they're starting to succumb to some of the other variants that perhaps they've not been infected with. So this virus, again, is generating infectious pools very quickly, very rapidly, and very successfully, and certainly is not a seasonal endemic virus. I seem to be laboring that point, but I'm doing it for a reason. And one of the major reasons this is important is because whilst we think back to 2021, with the success of our vaccination program, and we all felt that we did a tremendous job, and the NHS did do a tremendous job of particularly protecting those older patients who were very much exposed to severe disease at the time. Unfortunately, the fact is that if you look at our population as a whole, this is color-coded for people that have been very recently vaccinated, just over 6 months ago, or not at all. If you look in particularly younger age groups, you see that actually the proportion of people that have actually ever received a vaccine, it gets very, very, very large indeed. And in particular, this always concerns me, that something like a third of under 40s haven't ever had a SARS vaccination. And based on that, you can see why, given the fact that infection-induced immunity can be questionable sometimes, which I'll talk about shortly, you can see why this susceptible pool of infection is constantly being regenerated through the country, and why these waves are able to be sustained. So again, if we're not doing anything other than relying on vaccines, if we're not doing anything other than relying on infections to generate the immunity in our population, this is the problem that we face. And the particular thing that I want to draw your attention to here is that in our children, in those under 11 particularly, but to some extent in under 18s, the level of vaccination coverage is extremely poor. Now, I don't think that this situation was particularly helped by some of the messaging that was announced when this, particularly the under 12s vaccination scheme was announced back in the UK, back in 2022. And for that reason, I think that's not really helped breed confidence in the vaccination program. And so we've ended up with fewer than 10% of our under 12 population having had 2 shots of the vaccine. Many of them only actually had 1 or 0. So this really is a worrying situation should there be a change in the scenario. But it's interesting to think about why perhaps some of these messages were coming across the time. And if you think about it, you know, logically, this virus is something that predominantly affects older people. It predominantly, particularly at the beginning of the pandemic, was affecting older people in terms of killing them, unfortunately, and in terms of having poorer vaccine responses, and in terms of putting older people into hospital. And you can see these data from UKHSA and the ONS have compiled these into these nice heat maps here. So over time, and unfortunately the ONS catastrophically was ended back in spring, we can see that these data really quite clearly show a picture that older people are the ones we should be focusing on. And certainly in the initial timing of a pandemic, that is absolutely the case, and it absolutely was the case, and it was absolutely the right thing to do, to extend our vaccines first to those most vulnerable in terms of age and disease and comorbidities, etc. But it's not the case that younger people are completely without consequence. And I'll talk a little bit about that now, because it's really important for the future and in terms of what we see going forwards, okay? Because the problem is that children aren't just small adults. They are very different in terms of their immune systems. They're very different in terms of the way they respond to disease and in terms of the way they get over it. And of course, setting something up during a younger person's infection could change the course of their life without us knowing what the consequences might be. And there's certainly been some instances of that coming up. It was thought early during the pandemic, which has now been very widely debunked, that children were very different and they didn't get sick because they actually didn't transmit the virus or weren't infectable by the virus. And we know now that that's not correct. We know now that they make the same responses, they get infected by these viruses, but they're very, very good generally at defeating it, which is very unlike most adults, okay? We know that actually the predominant response that children tend to have is a very, very powerful innate immune response. So that's the non-targeted, innate sort of bells, traps, whistles, and pitfalls that try and trap a virus and demolish it before it really gets going, rather than eliciting these adaptive T and B cell responses that are much more important in adult disease. And indeed, many children that get infected with SARS and also with influenza don't actually what we call seroconvert, i.e. they don't produce that adaptive response, which gives them immunological protection the second time they experience a pathogen. But that shouldn't really matter if your innate immune system is so robust that you don't become disease or symptomatic, okay? And there are various different reasons why people think that these differences in childhood immunity lead to less pathology upon SARS coronavirus 2 infection. It's really important because there are some childhood aspects of this disease that are child-specific. And in particular, there's this dreadful condition, multi-inflammatory syndrome with COVID, or PIMS-TS as they call it in the UK, which is a very strange presentation. It's resembling Kawasaki-like diseases. It's sort of a delayed hypersensitivity type reaction to the infection that people have, depending sometimes on their HLA types. But the good news is that, especially since Delta came and went, and with the advent of childhood vaccinations, the incidence of this really has gone down. But that's partly, again, unfortunately, due to infection, which isn't a great way to do it. So this is great, having this robust infection protection from innate immunity, apart from the fact that this virus is quite wise to this. Now, you'll hear a lot about Omicron being, in so-called terms, mild. And certainly the first Omicron that evolved, the Omicron 1, the BA1, BA2, definitely had a preference for the upper respiratory tract. And it was also pretty bad at resisting the innate immune response. So in children in particular, it was thought that this disease really was even milder than previous SARS-CoV-2 variants. So what these graphs are showing you is that this virus, the Omicron, is increasing our innate immune response, whereas these other forms of the virus, apart from the original one from Wuhan, are able to suppress that response. So these are interferon-stimulated genes, which are the sort of strong arm, if you like, of the innate immune response. So over time, all these different variants are causing us lots of problems, and Omicron seemed to be a breath of fresh air because it really wasn't very good at doing this. Unfortunately, if you think about what happened with Omicron, it emerged into the human population. It was new, and viruses adapt to us as much as we adapt to them. And as we can see, unfortunately, since BA1 and 2, subsequent versions of Omicron have become very good at defeating the innate immune system. And they're getting better and better and better. And the XBBs, and indeed probably the BA2.86, seem to have characteristics that are indeed better at evading the innate immune response. So if you're a kid and you perhaps have only seen an infection and you haven't seroconverted, and all of a sudden you get hit by a variant that is very good at overcoming innate immunity, you could definitely be in trouble. And indeed, this needs to be considered on a population scale, because in the UK, and as I've just shown you, it's very easy to look at that age-related distribution of deaths and hospitalizations, et cetera, et cetera. And so we need to stand back and think about childhood COVID, not in relation to adult disease, but in relation to other childhood diseases, which we know that we always have huge vaccination programs targeting, because we know that they are important killers and indeed disease-causing chronic disease-causing agents. And if we take that step back on a world scale and consider countries like the US, who perhaps didn't control their childhood COVID wave quite as well as us, they didn't shut as many schools, etc., etc. There are a profound number of childhood deaths, unfortunately, and equatable to many of the other sort of vaccine-preventable diseases that they would otherwise vaccinate for. The US, thankfully, has mounted a huge vaccination program offering it to all children over 6 months. And indeed, on a population scale worldwide, the death toll, and just focusing on acute disease at the moment, does seem to be quite catastrophic in terms of young children. UNICEF estimates something like 17,000 children have died, but if you apply this is only in counted cases, so people that have had tests, if you apply that to what people consider to be the true death rate and excess mortality caused by COVID, scaled by the number of percentage of deaths that are usually caused in children, this could be anywhere over 60,000 young people as of the end of 2022, probably higher now. So this is not meaningless. This is not something that you can just assume that kids will be okay with being infected by. And indeed, it's just as bad as Haemophilus influenza, meningitis, and almost as high as measles in terms of the sorts of diseases that we actually usually have worldwide vaccination scale programs for. So this is a serious problem in children if you look at it from the perspective of pediatric disease rather than comparing it to adults. And you can see that in the UK. And this is just a graph of hospital admissions. There's no point looking at prevalence now, unfortunately, because they're not counting. But what you can see is that, particularly in younger children, we're still seeing the levels of hospital admissions that we saw back in the Delta and Alpha, indeed exceeding in some cases the Delta and Alpha waves. These are the first Omicron waves, and it's really got still the same sorts of level that we've had since. And this is important because if you consider where the UK instigated its vaccine programs, we were slightly behind the curve. So Europe instigated their children's vaccine programs back in the summer of 21 in the younger children, way before children went back to school after summer. And certainly they instigated their younger children vaccine programs well before we did in April 2022. And if you think about it, if we'd have perhaps done this sooner, we may have avoided some of these peaks that we saw with the BA1 and BA2 waves in children, because no matter how individual risks may have dropped because of immunity, because of different properties of these viruses, if you scale that by prevalence, what you see is, as I mentioned at the beginning, a small percentage of a very large number still translates to a very meaningful number of children that are unfortunately put in hospital. And this isn't trivial. And as I'll come on to, this does actually translate into very severe cases in hospital quite a lot of the time. Unfortunately, we've stopped giving the vaccine to children turning 5 as of last year. And indeed, the generalized vaccination program in kids stopped earlier this year, along with boosters, et cetera, et cetera. And we're now just trying to treat this like influenza in terms of our vaccination program, targeting very small restricted groups of the elderly and clinically vulnerable in inverted commas. The problem, of course, is how you define those groups. So this is a real problem. And I'm just showing this to show that this has been properly, this isn't just looking at running trends in data. This has been properly analyzed in retrospective cohorts, huge granularity of data done by Catherine Brown, Christina Pagla and others, showing that indeed in the Omicron waves, these huge waves of prevalence did indeed translate to massive numbers of children, unfortunately, going into hospital. And for some bizarre reason, this just wasn't connected with the mitigations that people were putting in place at all. And much of the myths that you'll hear about this is just children infected, happen to have COVID and we're in for something else. That really isn't true, I'm afraid. So, oh, sorry, this is the age one. So half of those are under 10, and in, I'm on the wrong slide. I do apologize. And yes, most of these are actually causative. The virus is causing the hospital admissions to be sent in. Okay. And as I mentioned, this doesn't just mean a couple of nights on the ward. This can indeed translate through to HDU and ICU admissions in children. And of course, pediatric ICU is not as well resourced as adults, but it does turn out to be the case that particularly in children under 5, this puts them at increased risk of hospitalization and severe hospitalization, about equivalent to our vaccinated population, or at least half vaccinated population in our 40s and 50s, which is quite staggering if you think about it. And it certainly doesn't come across in most media coverage of childhood COVID. And again, I emphasize that a small percentage of this very large number is still a considerable problem. So what's been happening? Well, the problem is that with unmitigated prevalence, we've seen huge amounts of transmission in children. You can see these are the first two Omicron waves, and you can see that massive amounts in this red line of the youngest children at schools were infected during these first two waves. Now, unfortunately, this is not the way to go about it, but the infection scale in this case was enough to induce a degree of immunity in these children, which has dampened down the prevalence that they've seen since. And so whilst we're not really vaccinating, these children are becoming immune just by virtue of the fact that having so many different experiences of this virus. In 2023, this started to come back up again because the immunity they've gained to these variants is no longer applicable to the ones that are circulating. And if you look at the cumulative infections in these age groups, it means that all of these children have been infected on average at least twice. And you can see that with age distributions in reinfections, if you calculate it here, something like 48 or 10% of these children are experiencing infections and reinfections from this virus. So this infection-induced immunity that they're obtaining isn't effective at all, unfortunately, at preventing the next infection. And this is just another graphical way of showing this. And in particular, once kids go to school, you can see that they start to get these high levels of reinfections compared with the younger kids before they go to school. So if ever there was a case for preschool vaccinations, including COVID, I would suggest that this is the case. And just to dwell not too long, but unfortunately on a very sad note, that this does sadly translate to children dying. Again, not in massive numbers as we've seen in adults, but in numbers that are significant compared to other childhood infections. And something over 170 odd, 180 odd children have sadly died in the UK from COVID, with about 70% of those being the underlying cause. And of course, there is actually a lag because all child deaths have to be referred to a coroner. So it's not the case, unfortunately, that these viruses are not causing disease in these children. People will talk about the relative individual risk of children dying compared to so many infections. But if you translate it to the actual reality of how many children are dying from these infections, it's far higher, for example, that measles was before we introduced measles vaccines, etc. It's certainly higher than influenza. So this is not a trivial matter. And again, if you compare the incidence and proportion of all deaths in these age groups compared across ages, you can see that, again, there's this almost U-shaped distribution where deaths in younger children are significantly increased compared to sort of slightly older children. And then you see this sort of age-dependent increase going up here. What is good to see, though, is that our vaccines are doing a very good job of protecting the older age groups from this increase in death that we saw in the first couple of years of the pandemic. So just imagine that we could flatten these lines as well. Wouldn't that be advantageous? I certainly believe so. I mentioned that infection-induced immunity isn't great, and the reason for that is because, again, this virus being so complicated and evolving means that the actual pattern of infections and vaccinations that we experience in our lifetime affects how good the next response will be. And there's a huge amount of work doing on this. I'm just highlighted one paper by my colleague Danny Altman and Rosemary, his wife, where they showed that you could confidently predict how good or bad someone's immune response will be to the next variant coming along, depending on which virus they've been exposed to or which variant vaccines they've been exposed to. And certainly this occurs in extremis for children because they don't have the advantage of having that initial priming from a vaccine. So they're dependent entirely upon infection-induced immunity. And this phenomenon is what we call immune imprinting or original antigenic sin, where basically the responses are similar enough to the last infection you've seen to elicit the same response against the virus. But unfortunately, that response, because the virus has changed very subtly, doesn't work. And so it's a real problem because, again, combined with the lack of seroconversion that we see in some children when they get infected, this means that infection isn't giving great immune protection for everybody. Now, you'll hear a lot about things like hybrid immunity and infection-induced immunity, meaning that we can stop worrying about this disease. It's one reason why the Living with COVID strategy has been so strongly supported by some. And indeed, if you look at the outcomes of infections versus vaccinations, you can see that, yes, you do see population immunity induced by infection. Of course you do. That is something that will happen. Like infection-induced immunity, vaccine-induced immunity wanes. This is showing that vaccines on top of a previous infection are indeed better. This is a very sort of well-regarded paper, which many people use to support the idea that infection-induced immunity in children is best. And this is a vaccine trial comparing under 5 to 11-year-olds with the Pfizer vaccine. So they're saying that, vaccinate on top of an infection, great. And in fact, your protection from an infection is better than the protection that you get from a vaccine. Although the caveat being, of course, that childhood vaccines are a lower dose, and we only give 2 doses rather than 3, 4, or 5. So who knows if we're doing this properly? Unfortunately, studies like this suffer from an inherent survivorship bias, because if you then compare how we got to this story, getting to this successful immune response, which we're measuring in the arms of children, you can only really measure the response in the arms of children that survive or didn't happen to be in hospital at the time. And unfortunately, if you look at the people that have just been infected, you see that this causes much more profound harm compared with the vaccinated population, including deaths. And this is in a US cohort. And, the advantageous amount of immunity that you're getting here could almost certainly be improved upon with the vaccination here if we were doing 3 or 4 or higher dose immunization in these children. So the idea that infection-induced immunity is superior to vaccines, or this hybrid immunity, can be true for the short term, but it comes with an inherent risk. And indeed, the investigators here showed that everyone, including infected and vaccinated cohorts, needed boosting to improve these immune responses and increase their longevity. So the notion that hybrid immunity, or indeed infection-induced immunity, is superior is always flawed by this idea that the reason we invented vaccines in the first place, the reason that variolation stopped and vaccination continued, is because it causes less harm to people than the vaccine, than the infection. So after that, now I'm just going to very quickly move on to long COVID in children, because it's something I care quite deeply about. I work with a charity about this, and just to emphasize that long COVID in children can be very similar, but also have some slight nuances compared to the disease in adults. And it is, unfortunately, if you extrapolate that graph that I showed you at the beginning, the case that many thousands of children have actually been living with long COVID since the very beginning of this pandemic. And that really is problematic, because if we're talking about the amount of school that's been missed by the lockdowns and things, and of course there should have only ever been one lockdown ideally, you can see that these kids are missing huge amounts of school. They're not able to attend properly. It's taking them months and months and months, if not years, to get better. And this is a significant issue. And especially when the government is insistent on a lot of presenteeism and people attending school no matter what, you can see that these children are adversely affected and just unable to interact. And schools just simply aren't providing that online access and things like that kids like this could really benefit from. And of course, this is really devastating for a young life in terms of the quality of life that's lost, the education that's lost. You can see there's a huge variety of symptoms here. And just there are so many examples of children who have been reduced to being virtually bedridden 24/7, when previously they were fit and healthy, athletic, undertaking gym. So the story is very similar to things like MECFS. And it's absolutely devastating that not more attention is given to this amazing charity, Long COVID Kids, who are thankfully involved in the COVID inquiry, but not in as many modules as they would like to be. This is Sammy McFarland, the founder of that charity, with her daughter, who sadly does suffer from long COVID herself. So this is a really devastating disorder, which of course the lack of control of prevalence in schools in particular isn't helping. And of course, we would say, well, once you've survived one infection, surely that's the case that it's not going to happen. It's not going to get you again, long COVID. Well, unfortunately, in children, it does seem to be, again, different to adults. And this is data from the ONS. And this is showing us that if you have a second or third infection as an adult, you are indeed less likely to develop long COVID second and third time around, because you seem to be making a much better and broader immune response. But in children, although these confidence intervals are very large because of the lack of samples compared to adults, there doesn't seem to be much difference at all, if anything. And even though these are big, they're equally spread across both sides of the forest plot here. So by constantly reinfecting children, we still run the risk that a proportion of them, somewhere between 6 and 15%, depending on the different studies that we see, are indeed liable to develop this long COVID problem. And these have been replicated in various studies, one indeed by a study from long COVID kids themselves, and of course by Gavi. And what Gavi have been looking at, as well as long COVID kids, is that this idea is if you already have long COVID, and you go back to school after you've improved slightly and you then get COVID again, what are the chances of that making your situation worse? And unfortunately, it's very much the case that it can make the situation worse. And children who would have spent maybe months recovering and then going back to school, contracting COVID again because they haven't had vaccines, because they aren't seeing mitigations in the classroom. And unfortunately, that's exacerbating the problems, and it really does set them back. I know that Sammy's daughter has had that exact situation happen to her. So it's heartbreaking, really, to see this. And of course, we know by inference from adult studies that one of the things that will protect children from long COVID is vaccination, although trials on that are not forthcoming in any great number. But what we do see is encouraging, because we know that there are signals in certain trials who aren't necessarily weighted to give us a firm answer that perhaps is the sort of concrete things that evidence-based medicine might be looking at. But it certainly does seem to be the case that vaccination in children should be as effective as it is in adults. And just very lastly, in terms of the effects of COVID, I just wanted to touch on the idea that long COVID, the sort of classical cluster of symptoms, can be different to these so-called latent effects of the infection. These things that maybe are set in motion with your acute infection and then manifest months later in terms of a problem, in terms of coronary heart disease, for example, in adults, clotting disorders, etc., etc. And one thing that is very clear in adults and indeed in children now, which was controversial, but it does seem to be the case, is that early onset type 1 diabetes is increased since the pandemic compared to years beforehand. There are different studies contrasting results on this, but it's very much the case that if you compare lots and lots of different studies, there is clearly an increase in incidence, particularly in 2021 as opposed to 2020, I guess, because fewer children were infected here because of the restrictions that were put in place. There is almost certainly a signal that is showing us that this virus, like other viruses, does seem capable of triggering that immunological response that attacks the pancreas in these circumstances. And although I haven't had space to show this here, the severity, the manifestation of that disease in terms of the ketoacidosis that children exhibit when they are admitted to hospital in this way does seem to be more severe as well. So there's something very, very upsetting, very interesting going on here, which needs pinning down. But my view is that we should be applying the precautionary principle. And if there's even the faintest hint that this is happening, then we should be vaccinating children to prevent this and to help with long COVID, and indeed that danger of an acute infection going forwards. Now, I'm just going to whip through these because I put these slides in case we were talking a lot about ventilation, but we really shouldn't need a pandemic to tell us about how to clean the air. We've known about this for centuries, okay? And we really need to realize that actually aerosol transmission is very, very important to the transmission of this virus. It seems to be pretty much the major route of transmission in most circumstances. The direct contact transmissions seem to be fewer, of course, in poorly ventilated spaces. Both of these things are going to be happening all the time. And in a classroom where children are in poorly ventilated spaces and spending huge amounts of time, usually in one room, both of these modes of transmission really are going to be important. But this really is something that we could do something about. Distancing and things in a ventilated space would help sort this out, of course. And of course, wearing a mask, but that's a very highly controversial thing for anyone to say in the UK nowadays. We know that countries that apply these sorts of principles did better. So in particular, Southeast Asia have shown that if you deal with the airborne infection threat, then you do far, far better in terms of controlling your epidemic. This is data from the beginning of the pandemic here from the WHO. And indeed, we've seen this for other viruses that spread by the aerosol route, including influenza, but this is a particularly good example. And indeed, South Korea did really well in the second SARS, just using mitigation strategies, test and trace, wearing masks, improved ventilation, isolation supported by the government, etc., etc. And they did not have to have harsh lockdowns in the same way that the UK and other countries have, because they focused on washing your hands and keeping away from each other and not really focusing on air quality. And there are numerous studies in healthcare settings that show us how excellent this was. This is the one in Addenbrooke's, and it showed that even not just COVID, not just SARS-CoV-2, but all these other airborne pathogens can be reduced with HEPA filters. And similarly in schools, this has been shown, but we've known about this for decades. And these are papers I dug out from this fantastic website that this guy has put on from the 60s and the 70s, where people have assessed the quality of filters in different scenarios for reducing the number of particulates and indeed virus infections in these environments. So why aren't we doing more for this? Why aren't we implementing HEPAs in all of these classrooms? Why have we just got stuck with a carbon dioxide meter that doesn't really tell us anything in terms of what's going on, apart from the bad quality of the air that those children are breathing? Coming back to healthcare settings, something like a third of people infected in hospital towards the beginning of this year were actually nosocomial infections. This is data from Tom Lawton. And indeed, in healthcare settings, we seem to be completely abandoning any kind of patient safety in terms of infection control. And indeed, some trusts are actually advising their staff not to test for SARS-CoV-2 because of the amount of isolation time that they have to go through, which is quite upsetting because this is the place where people who are vulnerable should feel safe. And indeed, one of the charities that I work with, the Clinically Vulnerable Families, have surveyed many of their members. And so many of these people have unfortunately missed out on attending healthcare appointments because of the concerns that they have for the lack of mitigations in a healthcare setting. And I work in a hospital in a building down the corner from one of the major wings, and I am literally one of the few people wearing a mask, even at this time of year. So it does seem slightly crazy that guidance is telling us that we shouldn't be controlling airborne transmission in a healthcare setting where those most vulnerable patients, including cancer patients, etc., are visiting for their care. And sadly, the message doesn't seem to be getting through that the vaccines are going to do the job on their own either, because most of the people who are eligible for vaccines now, which is still a small number, aren't taking them up, which just seems crazy, but it's perhaps not surprising if you have a government and a healthcare system that is telling everyone that this virus is no longer meaningful, no longer important, no longer dangerous, and that we shouldn't pay any attention to it. My view is that living with COVID should be about understanding it and understanding how to prevent its transmission. It doesn't just apply to that virus, it applies to many others. But the benefit of learning from a pandemic would be that we can improve the outcomes for the one going forward. So I'll finish there because I realize we've only got a few more minutes left for questions. But I hope that I've convinced you that this situation is not predictable and that children, especially in the UK, are not being protected sufficiently because we cannot predict how this virus is going to continue changing. We know that the very youngest children, especially for their first exposure, are pretty high risk compared to older children in terms of their risk of acute disease. And of course, long-term disease can be a real problem in this cohort as well as in adults. And we know that these vaccines, especially the pediatric doses, are extremely safe in terms of symptom profile compared with COVID, which is of course what we should be doing. And of course, we should get better vaccines going forward. And I'll just finish by thanking these people who I've heartlessly fleeced all the numbers and graphs from to put this talk together. And I hope I've made sense, and I'll happily take some questions.
Thank you very much, Steve. And I wonder if anybody has questions. Sorry, I'm trying to get the chat open. I can't seem to open my chat. Here we are. So no questions in the chat. If anyone would like to ask Steve a question directly in the last few minutes, would they like to raise a hand or unmute and speak? Oh. In that case, I'll ask a question. So,
okay.
So I mean, it's a fascinating talk. Thank you, and I think it's hard not to be convinced that COVID is a continuing problem in this situation. From our perspective in TAPAS, we're looking at air quality and the role of that in generally in health. I mean, do you think COVID is so special that lessons learned from COVID don't apply to other diseases, or is it typical of other diseases in that sense, I suppose?
I think it's the first time we've witnessed a pandemic on this scale where we've been able to properly track what's happening. So, there are many parallels with 1918, 1919 in terms of the way it's spreading. It is a slightly different virus because it is so infectious. So its inherent infectivity was always higher than influenza, and it's got higher since. So as the virus has adapted to infecting humans, that spike interaction with ACE2 has got more and more avid, and it's become even better at infecting us. So that's one reason why, along with a fairly robust particle, considering what it's made of, that it can transmit to the aerosolized route. It's not true that flu doesn't. Flu can transmit through the aerosolized route, but of course, there's two factors in it. Well, there's multiple factors in an actual infection. The infectivity of the particle and the dose that you get as well, and of course, your immunity. So many factors contribute to whether or not an aerosolized transmission will result in an infection as such. There's a lot of kinetics going on there. But I do think that it's the case that, what frustrates me about the idea of we should just treat it like influenza is that we don't really deal with influenza particularly well. We somehow accept that we'll see a couple of thousand direct deaths and about 10 or 15,000 deaths with pneumonia every year, and there's not much we can do about it. But there really is more that we could do about it, and we showed that with the mitigations. And I think that we really must be careful if we don't take lessons from this pandemic experience and we revert to how we dealt with things prior to this in 2019, 2018. And what was really concerning for me is last year when we knew flu would come back in a big way because we hadn't seen the seasonal infections that we usually had. And there was no effort to improve the vaccination coverage across the board, which could have stopped that massive peak that we saw. And of course, what happened then was that we had flu, we had RSV, and we had SARS at the same time, and the NHS buckled once more. So I think we really need to learn from this. I don't think it's, I think SARS, it's special in the sense that it's behaving differently. Eventually it will become more manageable, but it's not the case that these viruses become benign over time. It's the fact that our immunity builds to protect us against it. So you stop measles vaccinations, you'll see measles outbreaks and you'll see encephalitis. So we are fortunate to be in a situation where we're complacent about these things because of vaccines and because of our prior immunity. So I hope we learn the lesson that if you can't achieve that, you have to do other things. And that's why cleaning the air is so important.
Yeah. Well, thank you very much. I'm just conscious of the time.
Yeah, there's a few in the chat.
There are a couple of questions in the chat. Maybe you could follow up with those individually. But just to say that the talk and the slides will be on our web page, and also if you'd like to get our sorry, I'm trying to do two things at once here, not speaking. If you want to get our newsletter, please sign up with us. And can I just advertise that next week, at the same time, we'll hear Ernesto Alfaro Moreno from the EU Horizon Learn project, who will talk about particulate matter in the air and what do we have to learn at schools. So very related, of course, to what we've just heard today. So I'll close now with thanking Steve for a very interesting talk. I thought this was fascinating, and it's been very interesting issues about COVID and air pollution. And thank you very much. And thank you all for attending, and I hope we'll see you all next week. Thanks a lot.
Thanks, everyone.